I remember this one specific week, must have been deep in 2020. I was on the phone with my sister, and she was genuinely panicked. She had just read an official bulletin from a major health organization that said one thing. Let's say it was about wiping down every grocery bag, every package, every single thing that crossed the threshold of your home.
I remember this phase so clearly.
She was spending hours a day just decontaminating her mail. Then maybe 2 days later, I'm watching the news, and a different official, somebody introduced as the top expert, gets on TV and says that's all basically hygiene theater.
Right.
He almost laughed it off. He said it was pointless, that the real danger was something else entirely. And I just remember sitting there staring at the screen and thinking, they can't both be right.
No.
This isn't a minor detail. It's a complete 180-degree reversal of fundamental advice, delivered with the exact same level of absolute certainty, all within 48 hours. What do you do with that?
You don't know what to do.
Do you keep wiping? Do you stop?
Yeah.
And more importantly, the next time they get on TV and tell you something is an ironclad fact,
Yeah.
how much are you going to believe them? That feeling, that moment of profound dissonance, it wasn't just confusion, it was a crack. It was the moment the very idea of the experts started to feel a lot less solid. And it turns out that single crack, that loss of trust, might have been a much bigger aftershock than the earthquake itself.
That specific anecdote, I mean, the shift from compulsive surface sanitation to just dismissing it as performance, it really captures the precise failure point we need to analyze.
It does.
And that's exactly what this deep dive is about. We're going into the systemic communication failures that happened during the pandemic and the resulting erosion of trust in public health institutions.
Right.
Our mission here is to understand the complex internal dilemmas that forced officials to make these compromises that, you know, they often chose not to share transparently with the public.
So it wasn't just what they said, but what they didn't say.
Exactly. We're looking at how these conflicting messages were driven not just by expected scientific uncertainty, which, I mean, is inevitable in a new crisis, but by three really powerful, sometimes unacknowledged forces: resource scarcity, political pressures, and this perceived need to control public behavior.
Okay, let's unpack this. Because what the sources are suggesting is the problem wasn't really a failure of the science itself, but a failure of communication strategy.
Yes.
And the very first section of our analysis gets to the heart of it, what you call the core dilemma. This tension between balancing transparency with panic control.
That's where the ethical minefield was laid. I mean, public health authorities, they faced this unprecedented strategic tension. They had to balance the need for full, transparent disclosure of a frightening, rapidly changing truth
Against what they thought was the necessity of managing public behavior.
Yes, they were terrified of panic. They were terrified of hoarding. They were terrified of chaos.
So they were basically operating under the idea that the public just couldn't handle the raw, evolving truth, that they felt they had to, strategically misrepresent or modulate their beliefs.
That's the assessment many critics later made. It was prioritizing a behavioral nudge over pure, unvarnished information.
But was it, malicious?
I don't think it was always intentional malice. It was often a perceived duty to persuade the public toward compliance rather than just informing them truthfully about all the knowns and the unknowns.
But the public, of course, doesn't see the risk assessment matrix. They don't see the fear of widespread panic going on behind the scenes.
All they see is the output. And that output was mixed, contradictory messages delivered with this inconsistent level of certainty. And that fundamentally is what eroded faith in the source itself.
This internal friction is. It's really perfectly captured by the clash between two key operational principles, the precautionary principle and the harm reduction framework. Now, these sound like they should work together, but they were constantly pulling officials in opposite directions, especially when resources were tight.
They are the philosophical scaffolding that underpins crisis decision-making. So let's look at how they diverge, because it's critical.
Okay.
The precautionary principle, or PP, is essentially better safe than sorry.
Right.
It encourages implementing really stringent, risk-reducing strategies, even when the scientific data is uncertain, particularly if the risk of serious harm or death is high. It places this penumbra of precaution over decision-making.
So it's saying, Don't wait for absolute scientific certainty, which could take months or years. You have to act now to prevent the worst case.
Precisely. If the PP is advising a government, it would argue for an immediate, total lockdown, mandatory universal masking, and aggressive border closures the moment a serious new pathogen is identified.
Regardless of how thin the early data might be.
Exactly. The focus is on preventing catastrophe. Now, contrast that with harm reduction, or HR. HR is the pragmatic response. It's used when the safest or most scientifically ideal option, the one dictated by the precautionary principle, is simply not feasible.
And the constraint could be social, political, or in 2020, most often.
Resource scarcity. HR means providing a safer but realistic option. It meets people where they are.
Can you give us a concrete analogy to separate those two? Because they sound similar on the surface.
Sure. Think of managing a dangerous, icy road.
Okay.
The precautionary principle tells you to shut the road down entirely. The safest option is zero risk. No cars, no accidents.
Makes sense.
But harm reduction, knowing you can't realistically shut down the nation's transit system, tells you to impose a very slow speed limit, require snow tires, and prohibit all but essential travel.
It's not zero risk.
Not at all. But it dramatically reduces harm while acknowledging the constraints of reality.
And the fundamental failure then was that officials were using these harm reduction strategies, driven by resource limits, but they were presenting them to the public as if they were precautionary principle strategies.
That is it. Precisely. They were framing a compromise as the ideal solution.
As if it were the scientifically safest or only necessary option.
Exactly. They were reticent to acknowledge that both scientific uncertainty and resource scarcity were shaping their recommendations.
So instead of saying, look, we'd advise a 14-day quarantine, but since that's economically impossible for most people, we're recommending 10 days as a harm reduction compromise.
They just announced 10 days. And that made the public believe the science itself had somehow magically settled on 10 days as the perfect number.
Which then leads the public to suspect the science is either compromised or the scientists are incompetent.
Right. Rather than realizing that policy is almost always a painful trade-off, driven by pragmatic necessity.
We have no better illustration of this trade-off than the mask flip-flop of early 2020. I mean, this is the canonical example of resource scarcity, just completely overriding transparent communication.
It really is. Let's trace the timeline of that reversal because it's so telling. In January 2020, the initial guidance from public health bodies like the CDC recommended masks only for healthcare workers and individuals who are already showing symptoms. That was the initial posture.
But the sources we've looked at indicate that by late February, there was growing evidence, a lot of data coming out of Asia suggesting broader masking benefits. Yet the official stance held fast for about 2 critical months. Why?
That delay was driven almost entirely by the resource constraint. Public health leaders were consumed by the fear, a very real fear, that if they advised the general public to mask up, a wave of panic buying would immediately exhaust the already severely limited stocks of N95 respirators.
And the priority, understandably, had to be preserving those supplies for frontline healthcare workers who were facing the highest risk.
Of course. They felt they had to make a policy statement that masks weren't necessary for the general public, purely to manage a supply chain crisis.
So the communication was tailored to the scarcity of N95s, not the evolving science of transmission.
Exactly. But as science often does, it changed the game. New data on asymptomatic and pre-symptomatic transmission people spreading the virus before they even felt sick, it made that initial stance medically untenable.
Because if people could spread the virus without knowing it, then universal source control was essential.
It was the only logical next step.
Which is what led to the abrupt reversal on April 3, 2020.
Yes. The CDC abruptly urged universal mask use, but crucially, they specifically recommended cloth masks.
Ah, that's the key detail.
This was the textbook harm reduction move. They couldn't give everyone N95s, so they offered the feasible, widely available option of a cloth mask. It was a clear shift to acknowledging community transmission while still trying to protect the healthcare supply.
What was the devastating long-term consequence of this initial delay and then the reversal, specifically for public trust?
The damage was immense and multifaceted. First, it immediately provided political opposition, those who wanted to downplay the severity of the crisis, with powerful, simple ammunition.
Right, they could just point and say, see, they don't know what they're talking about. They flip-flopped.
Exactly. Second, It severely undermined the credibility of the public health experts who were now trying desperately to instill widespread behavioral change. I mean, how could they demand compliance now when they had just spent 2 months telling the public the exact opposite?
That's a huge problem.
And third, and maybe most damaging, it created this lasting public belief that when experts speak, their statements might be motivated by resource management or politics rather than by pure, unbiased science. That feeling, that doubt, became a poison pill for the entire response effort.
It's clear that prioritizing this behavioral persuasion over transparency, set a pattern. We saw this policy roller coaster continue across several crucial areas of the response between 2020 and 2022. The consistency problem wasn't a fluke. It was systemic.
It was. The documentation of systemic inconsistency shows that public health policy was constantly being shaped by these dynamic, non-medical pressures, politics, economics, logistics, and these pressures often created policy shifts that just looked chaotic to the public eye.
Let's break down the major areas, starting with travel restrictions. The progression here was lightning fast and, frankly, very confusing.
It was incredibly volatile. The guidance began in December 2019 with a mild practice usual precautions, a level 1 notice for China. Within weeks, it escalated to a level 3, avoid all non-essential travel notice by late January 2020.
And then came the bans on foreign nationals from an expanding list of countries: Iran, Europe's Schengen area, Brazil, that rolled out through the spring.
The sheer speed of those changes was disorienting for everyone.
And the measures they did put in place, well, they seem to have some shaky scientific foundations themselves. I'm thinking specifically about the airport passenger screening.
That's a perfect example of a high-visibility, high-cost measure that proved to be pretty ineffective.
It was a major, expensive undertaking, financially supported by the CDC.
And yet it was stopped entirely in September 2020. And the reason they gave, the rationale, was that it had limited effectiveness due to the high prevalence of asymptomatic cases, people traveling and spreading the virus without showing a fever or other symptoms.
But the knowledge of asymptomatic spread was available much, much earlier than September 2020. So that makes the decision to stop it look less like an adaptation and more like an admission of a delayed failure.
It appears that way to the public. The interpretation is, why did we spend months and millions on a system the experts should have known was flawed from the start?
This kind of retrospective policy justification only amplified the sense of chaos.
And then, of course, the mandatory testing requirements for air travel just fluctuated wildly.
They were introduced, then they were tightened from 72 hours to 24 hours pre-departure for the Omicron variant in late 2021, and then entirely eliminated in June 2022. And the constant chopping and changing, combined with the difficulty and expense of getting rapid results, just made those requirements so controversial for travelers.
And you mentioned the political dimension earlier. The March 2020 European travel restrictions were strongly criticized by the European Union, and the initial China bans faced accusations of xenophobia. So even when officials defended these as necessary, the perception of inconsistent application meant that skepticism was just layered on top of every policy.
Moving on, the quarantine decisions were another source of massive friction. The 14-day standard was the gold standard, but it just seemed to melt away under resource pressure.
The initial 14-day standard was the most protective measure, yeah. It was derived from the estimated incubation period. But the first signs of compromise came very early, in April 2020.
That's when we saw exemptions for essential workers, healthcare staff, grocery store employees.
Right. They were exempted from post-exposure quarantine, and this was explicitly driven by personnel shortages. The system simply could not afford to lose those workers for 2 weeks at a time. This was a clear case of harm reduction overriding the precautionary principle because the workforce constraint was just too severe.
And later that year, the rationale for shortening quarantine for the general public shifted explicitly to economics and compliance.
Yes, in December 2020, the recommended self-quarantine was reduced from 14 days to 10 days, or even 7 days with a negative test.
And the CDC was actually pretty transparent about the aim there.
They were. They stated the aim was to encourage more people to quarantine for a shorter period by reducing the economic hardship associated with a longer period. That's a classic acknowledged harm reduction policy.
They were accepting a slightly higher theoretical risk of spread
in exchange for higher practical compliance and a lower economic burden.
But the most controversial change had to be reducing the isolation period for infected individuals from 10 days down to 5 days in December 2021. This was a lightning rod for criticism.
It drew fire not just from the public, but from within the public health expert community itself.
So what was the CDC's justification?
They justified the 5-day isolation period by citing data showing most transmission occurs early in the illness. However, critics argued the change was rushed, that the CDC hadn't adequately consulted external public health groups, and, most damagingly, that the rationale for the policy was just poorly communicated.
What were the specific concerns that other public health experts were raising?
They pointed out that while transmission might peak early, many people remain infectious past day 5, particularly without a negative rapid test to exit isolation.
Right.
Furthermore, medical unions and professional societies questioned the speed and the seemingly unilateral nature of the change. They suggested it was driven more by the need to get workers back into the economy during that massive Omicron surge, a workforce constraint, rather than a definitive change in the pure clinical science.
And when a policy shift lacks transparent scientific consensus, experts outside the institution feel they have to speak out.
Which, of course, further confuses and alarms the public.
Finally, we have to look at social distancing and lockdowns. These are the measures with the most profound societal consequences. I mean, massive unemployment, educational disruption, and they became heavily politicized very, very quickly.
The sheer cost of these measures, the 6-foot rule, canceling large events, meant that the decision-making around lifting them was inherently political. The economic stakes were just too high to remain purely scientific.
And in the spring of 2020, we saw some early evidence of political influence potentially overriding public health expertise, specifically concerning the reopening guidance.
The sources reveal a very telling incident. The CDC compiled detailed reopening guidance in mid-April 2020, but the initial report was reportedly rejected by the administration at the time.
In favor of what?
They ultimately adopted guidelines that gave significantly more discretion to states, allowing different states to choose different reopening timelines based on their local priorities. This fueled widespread concerns about political and economic considerations, just overriding the consolidated public health consensus.
And even seemingly minor changes met with backlash, like reducing the distancing recommendation for schools from 6 feet to 3 feet in March 2021.
That shift, which the CDC stated was due to emerging data, met swift backlash from teachers' groups.
And their skepticism was centered on what, exactly?
On whether the change was truly driven by new scientific findings, maybe about aerosol transmission risk, or whether the primary driver was simply the desperate need to address classroom capacity issues and get children back into buildings.
So if 6 feet was the scientific necessity for a whole year, moving to 3 feet, especially without exhaustive public consultation, led many to believe the policy was caving to logistic pressure rather than new data.
It's just abundantly clear that this policy inconsistency was systemic, driven by that unacknowledged conflict between what the science recommended and what societal constraints allowed.
So now let's pivot to the measurable impact of all this chaos. We can move past anecdotes thanks to some fascinating infodemiology studies, analysis of social media discourse that quantified the emotional and psychological reaction to these policy shifts.
This quantitative evidence is so crucial because it moves the discussion from, people felt confused to we can actually measure the precise drop in trust and the surge in polarization.
And what did the data show?
The data analyzed U.S. Twitter discourse following the major shifts in CDC mask guidelines.
And the overall response pattern was striking. It seems the public responded negatively and with less trust following shifts in the guidelines, regardless of whether the guideline was restrictive or permissive.
That is the core takeaway. The policy change itself became the enemy of trust. Let's look at the numbers.
Okay.
Following the 2020 recommendation, that abrupt move to universal masking in April, the level of trust expressed in mask-related tweets decreased. The analysis assigned a beta coefficient of negative 0.004.
Now, for listeners who might not be statisticians, how should we interpret that beta coefficient?
Think of it this way. When you see a negative coefficient linked to trust right after a major change, it confirms that the communication around the change, the confusion, the abruptness, the lack of context outweighed any potential positive impact the new policy might have had.
So it was a net loss for institutional credibility.
A net loss. And furthermore, the discourse immediately polarized. Mask-related tweets went from being generally more positive than general COVID-19 tweets before the recommendation to seeing a marked increase in negative sentiment right afterward.
Okay, so then we get to the relaxation. In May 2021, the move away from masks for vaccinated individuals. Did people finally celebrate and reward the CDC with renewed trust?
No. Following the relaxation, levels of trust decreased again. This time the beta coefficient was negative 0.0001.
So the drop was less severe than the initial flip-flop.
It was, but the underlying emotional climate was far worse. Mask-related tweets in 2021 were found to be substantially more negative than comparator tweets about COVID-19 in general.
That suggests a tremendous amount of pre-existing fatigue and cynicism had built up. The public was angry, and it seems like no matter which way the policy moved, the anger was just directed at the source.
Precisely. The data confirmed a sharp decrease in neutral tweets following both shifts. Neutrality vanished. People stopped being indifferent and moved straight into these highly charged positive or negative camps.
So the shifts were perceived as institutional inconsistency.
And that led to a breakdown in consensus and severe emotional polarization, fear, anger, cynicism, which we can now actually quantify.
This brings us to the communication critique. Why did traditional transparency fail? Why did the public read the evolving nature of science as a fundamental lack of credibility?
This is what we can call the inconsistency trap. In a novel crisis, the complexity of recommendations and the constant reversals created a kind of catch-22 of risk communication.
How so?
When officials communicate uncertainty saying, "We think this, but we don't know for sure," the public, especially when they're fearful, they often don't hear, "Scientists are responsibly learning new things."
They hear, "The people in charge don't know what they're doing."
Exactly. And that perception that scientific uncertainty equals flawed science had devastating behavioral consequences.
It led to reduced compliance and, like you mentioned in your opening anecdote, counterproductive behaviors like hoarding supplies, driven by this personal need to control risk when the official guidance seemed unstable.
The public needed stability and clarity, and what they got was complexity and reversal.
So let's discuss the most egregious failure in risk communication, what's called non-transparent persuasion. This is where officials consciously prioritized behavioral nudges over fully truthful disclosure.
The intentional shifting of goalposts is the classic example cited in our sources. This involved a chief medical advisor who repeatedly raised the estimated herd immunity goalpost, moving it from 60-70% up to 85% over several public statements.
And his later justification for this incremental shift was that he was trying to accommodate what he felt the public would accept. He aimed to persuade them toward vaccination, rather than fully informing them of his true scientific calculation at the time.
That decision created a foundational crisis of trust. When officials manipulate numbers or omit key context to achieve a behavioral outcome, even a beneficial one, like promoting vaccines, they violate core transparency standards.
It suggests a very paternalistic view, that the public needs manipulation rather than empowerment through information.
It does. And one of the most significant transparency violations was the failure to properly communicate risk, often relying on misleading relative risk rather than the crucial absolute risk.
Let's spend some time on this distinction because it's critical to understanding vaccine hesitancy.
It's a crucial technical point, but one that drastically changes perception. Relative risk describes how much a risk is reduced compared to an existing baseline. So claiming a vaccine is 90% effective means your chance of getting sick is reduced by 90% relative to an unvaccinated person.
Which sounds fantastic and very dramatic.
It does. But if the risk of a severe outcome is already incredibly small for a certain demographic, say healthy people under 30, that 90% reduction might be masking a tiny real-world change.
Exactly. And that's where absolute risk comes in.
Right. Absolute risk communicates the actual magnitude of the risk. So if, hypothetically, your chance of being hospitalized is 1 in 10,000 without the vaccine and 1 in 100,000 with the vaccine, the absolute benefit is a reduction of 9 incidents per 100,000 people.
And officials often avoided these specific absolute numbers.
They did. So when they claimed a vaccine was 90% effective, using that relative risk, but people saw vaccinated individuals getting infected during a surge, the public thought the experts were either lying or incompetent. They conflated effectiveness against severe disease with effectiveness against any transmission at all.
It was a disastrous misalignment of messaging. The perception gap just became too wide.
Those high effectiveness claims, the relative risk claims, they just didn't hold up against the observed reality of infection, particularly as new variants emerged. The public was trying to make sense of, if it's 90% effective, why is my vaccinated neighbor sick?
And the answer lies in the base rate, which was never clearly communicated using absolute numbers.
And this inadequate communication specifically fueled skepticism among the vaccine-hesitant public. We have data on this.
What did it find?
A targeted study of COVID-19 vaccine-hesitant individuals found that roughly 35% reported becoming more skeptical toward vaccines because of the communication efforts of officials and scientists.
So the communication itself was backfiring.
Massively. This group overwhelmingly cited the incomprehensibility of the communication as the reason for their increased distrust.
What were the primary pieces of missing information that the vaccine-hesitant public wanted but felt was being withheld?
First, they cited the need for detailed and numerical information on vaccine side effects. They felt they were being told the vaccine was safe without sufficient transparency about the actual quantified low risk of rare adverse events.
And the second thing.
And crucially, they wanted the benefit to harm ratio presented in clear, absolute numbers. They needed transparent, unvarnished data, not these highly optimistic percentages, to make their own risk assessments.
And when that detailed information is withheld, it just feeds the narrative that institutions are hiding something.
Exactly.
So if the collapse of trust was a measurable, predictable result of these communication failures driven by scarcity and bad framing, then the vital question is, how would we rebuild it for the next crisis? What are the concrete lessons learned?
The commitment has to be to radical, consistent transparency. The good news is that public health institutions are recognizing these failures and are proposing concrete reforms. For instance, the CDC itself acknowledged shortcomings and began planned internal overhauls in August 2022.
What were the main areas of focus for the CDC's internal restructure? What was it designed to do to regain public faith?
The overhaul focused on three major areas. First, a fundamental shift in data culture, generating and releasing data more efficiently. Moving from a culture of data for publication, which is slow and academic, to data for action.
Getting timely vetted data out into the public square instantly.
Exactly. Second, consolidating command structures to ensure that only one consistent voice was communicating from the top, to eliminate the conflicting messaging we saw. And third, comprehensively improving communication strategies with the general public.
And beyond the internal plumbing, experts have outlined specific, structured ways to communicate scientific uncertainty without sacrificing credibility. This is about changing the very language and format of the message.
It's about setting expectations. The core recommendation is to implement a standardized system to indicate the CDC's level of confidence and the current level of scientific understanding in rapidly released data.
That seems essential. It labels provisional data as provisional, so the public knows they are looking at preliminary results, not settled science.
And it moves away from language that implies finality. You have to use non-absolute language consistently.
So phrases like, the current evidence indicates that, or based on preliminary data, we are confident that.
Those must replace definitive absolute statements like, we are sure that.
And authorities need to prominently and repeatedly state that information and guidance are provisional.
And that they are likely to change as the science evolves. This effectively disarms the inconsistency trap by building change into the foundational public narrative from the start.
And circling back to the danger of relative risk, how can risk messaging formats be reformed to ensure full transparency using those crucial absolute numbers?
The solution lies in structured, fully transparent formats. This means the default presentation of data must describe both benefits and harms in terms of absolute risk. This avoids the misleading framing of relative risk and ensures the public understands the actual magnitude of protection.
But how does this translate into a format that the average person can easily absorb? Because presenting complex absolute risk numbers can quickly become dense and overwhelming.
The recommendation is to utilize tools like fact boxes or concise summaries. You can think of it like a standardized nutrition label for a health policy.
I like that analogy.
These tools present evidence clearly, listing outcomes as absolute risks for distinct populations. For example, detailing the risk reduction per 1,000 or 10,000 people. This makes objective comparisons easy and respects the public's intelligence by giving them the unfiltered data they asked for.
Finally, we saw how politically charged and federalized the messaging became. How do you ensure these transparent, consistent messages actually reach a skeptical public at the local level, avoiding the politicization that targets federal agencies?
The key is diversifying the messengers. Public health has to move beyond relying solely on federal figures like the CDC director or the chief medical advisor.
You have to leverage diverse, local, and trusted messengers.
That's it. Religious leaders, local business owners, school superintendents, community health leaders. When the accurate information is disseminated locally by people the community already trusts, the message is consistent, more trusted, and it bypasses that immediate political filter that gets applied to federal pronouncements.
Reflecting on this deep dive, it seems the collapse of public trust wasn't a random event at all. It was the predictable consequence of navigating a highly complex, often unacknowledged ethical minefield between scientific uncertainty, resource scarcity, and this perceived need to manage public behavior.
That is the essential summary. Public health leaders were forced into these uncomfortable trade-offs between the ideal safety of the precautionary principle and the pragmatic compromises of harm reduction, often driven by immediate scarcity or political pressure.
And their decision to prioritize behavioral persuasion over radical true transparency, as we saw with the mask flip-flop, the intentionally obscured goalposts, and the reliance on misleading relative risk data, it created an environment where consistency was paramount.
And inconsistency was viewed not as expected scientific evolution, but as compromised expertise.
And the measurable data confirmed that every major guideline reversal, whether it increased or decreased restriction, resulted in polarization and a drop in public trust. It means the public's frustration was fundamentally centered on the delivery of the information, not just the content of the policy itself.
The ability of public health institutions to effectively respond to future crises depends entirely on maintaining public trust. And this can only be achieved through a commitment to clarity, consistency, and above all, radical transparency.
Honestly communicating what is known, what is unknown.
And the specific non-medical factors like resource shortages or political constraints that are driving necessary policy changes. The challenge remains how to make complex, nuanced, uncertain information clear, concise, and applicable for the public, especially for those who are already skeptical.